Hello, everyone. Welcome to Hot Seats. I'm Omid Moghaddas from Tehran, and once again, I'm so grateful and honored to be your host from this educational platform. And today, I'm super excited because a dear friend and a master clinician and one of the true educators I believe I've seen in my career, in my life, Steve Chu is here with us from New York. Hello, Steve. Welcome to Hot Seat.
Hi, Omid. Thank you for having me.
Thank
So nice to see you again.
Thank you so much. And appreciate that you accepted this invitation. And we are so lucky as all audience to have you in this program and to enjoy your comprehensive and amazing presentation. In the previous session, we talked about different aspects in implant dentistry, about soft tissue, hard tissue grafting, designs of implants a little bit. We talked about some complicated cases, sinus grafting. But as I say all the time, at the end of the day, what is very important for our patients is the aesthetic and the predictability of the outcome and reducibility of that. So today's topic is aesthetics in implantology, and who can be better than Steve Chu to present this topic. I'm not going to go to the details now because I'm pretty sure when he starts his presentation, you will enjoy every second of it. And just as a tradition, before we start, I want to have Steve's CV for all of you. And then I won't make you all wait much longer to hear this amazing presentation. At the end of the presentation, we will have a little discussion together. Dr. Chu received his doctoral degree from University of Pennsylvania School of Dental Medicine in 1984, and his master's degree in restorative dentistry and certificate in postgraduate fixed prosthodontics from University of Washington School of Dentistry in 1986. He subsequently obtained his dental technician certification in dental ceramics in 1996 and ASMDT status in 1998 at New York University College of Dentistry. He maintains a dual academic appointment as a clinical associate professor in the Ashman Department of Periodontology and Implant Dentistry in New York University College of Dentistry and Columbia University College of Dental Medicine. He is the creator of Chu's Aesthetic Gauge, manufactured by Hugh Freddy, and he maintains a private practice in fixed prosthodontics, aesthetic, and implant dentistry in New York City. Dr. Chu has published extensively in the dental literature and has given lectures nationally and internationally on subjects of aesthetic, restorative, implant dentistry. He is one of the editorial review board of several peer-reviewed dental journals and recipient of the Distinguished Lecturer Award from the European Academy of Aesthetic Dentistry. So many publications, great contributions to many great books, and his latest publication by his colleague, and I can proudly call both of them my mentors over the years, Dennis Tarnow, Tooth Implant, is also out by Quintessence, which I truly myself recommend you all to read this book. So with that said, Steve, we are ready from head to toe to hear your amazing presentation. And as I said, at the end, we will have a fun discussion about the topic. Thank you.
Great. Thank you, Omid. Thank you so much. And I know that we had discussed about me coming to Tehran, to your beautiful country. So this is a nice alternative in the interim, but I look forward to being able to come to your city one day. Thank you. The topic that we wanted to really discuss about is really about immediate implants. And this hot seat conversation that you have, I think, is really a great forum because it allows us to really talk about some strategic topics over time. So I really would like to focus on this today, and as you had mentioned it before, really talking about the subject of aesthetics and implantology. And again, the hot seat forum, I think, is terrific. So one of the hot topics nowadays is really has to do with implant design. and how we can actually use that to maybe enhance some of our aesthetic outcomes. So we'll talk a little bit today about really implant designs and macro implant designs and how it can be used to enhance some of our aesthetic outcomes. As you mentioned before, is that we had just published this book with my partner, Dennis Tarnow, on the single tooth implant, but more importantly is really talking about really how to sort of take on the single tooth in more of a minimally invasive approach, meaning immediate tooth replacement therapy, or as what Joe Kahn would say, immediate implant and immediate provisional restoration. So I think that this has sort of changed our perspective in treatment in a minimally invasive way since, say, 1998, originally with Peter Worley, and then Joe Kahn in 2003. So really, what are the aesthetic risks? If we're going to talk about a hot seat conversation, what are really the aesthetic risks? And I think that obviously midfacial recession is a big problem associated with aesthetic problems, usually due to some type of collapse of the buccal plate, and then consequently, as a result of, say, losing the buccal plate, we not only have recession, but also soft tissue discoloration because you're seeing the implant through the area. And then the second variable will really be papilla loss. So we basically have two issues. We have potentially loss of the buccal plate, and we have loss of the interproximal attachment apparatus. And this is not uncommon. We see these patients that come in with aesthetic problems. You could see midfacial recession associated with this right implant. We could see discoloration of the tissue because there's really no buccal plate remaining around that implant. And you can see the darkening there, as well as the loss of the papilla. So these are very, very common issues associated with implant aesthetics. And the reality is that in the aesthetic zone, the margin of error is very small. And we have to really be very careful in the aesthetic zone because, again, if you're a little bit off, say like a 0.5 millimeter too far facial, maybe a 0.5 millimeter too close to the adjacent tooth, you have the risk of losing the papilla as well. And those are the two real factors that we have to contend with. So again, the labial bone plate and the interdental attachment apparatus can be compromised, and hence we can get some of these aesthetic problems. Let's talk about the first, which is really the labial bone plate. In regards to really the two factors that would sort of define it is really its dimension, and is it important not just to have labial bone plate around implants, but also how thick is that labial bone plate, or how thick should it be for long-term stability? And could perforating the socket or perforating the extraction socket be a variable that would then compromise our aesthetic results? For instance, if you had socket perforation, could that then compromise the blood supply to the residual buccal plate that could lead to its necrosis? And we'll discuss that, and I'll show an example of that case later on. So these are really the two factors. Do we have enough bone around the implant on a facial dimension? And could socket perforation compromise that buccal plate? Now, we know from all this, the work that was done, there's many studies out there that really talk about how thick is the buccal plate. And in reality, in most instances, it's very thin. Hence, we sort of learned from Mike Block's original work and work from Team Atlanta that socket grafting is really helpful, not from the standpoint of osseointegration, but from a standpoint of aesthetics, that we could then maintain ridge, volume, and shape, and hence actually maintain our aesthetics. And the beauty with immediate therapy is that if everything is there, we're just trying to maintain and preserve it. So the concept originally was just grafting where the buccal plate was, but we've also enhanced it to actually add graft material into the soft tissue zone. As you had mentioned, the work with Dennis, talking about the dual zone socket grafting technique, where we're bringing the graft not only to where the buccal plate is, but also into the soft tissue zone, containing and protecting it with our temporary, allowing the tissue to mature, and you could see then that we're able to maintain ridge, volume, and shape, as well as maximize our peri-implant soft tissue. So it serves as sort of a dual action as well as dual zone, meaning bone plate and soft tissue zone, so the two zones but also enhancing ridge shape and maximizing your peri-implant soft tissue. So these are really the key strategies, and we learned that grafting is very important for aesthetics. It may not be important for integration if you have enough gap distance, but in order to maintain or minimize ridge collapse and remodeling, grafting really helps tremendously. So we now routinely graft in the aesthetic zone. Now, if I have to look at some of the cases that we've done over the years, and we've done, literally probably thousands of patients over, say, the last 12 years, but there's a couple that have come back at recall that actually didn't turn out so great. And I think the question is really why. And it's a very interesting thing. There's a really interesting paper that just came out in IJPRD with Lynn Cooper and actually Homeless a Day, who's from, I believe, Turin as well. And they looked at, it's a randomized study looking at whether to graft the gap or not graft the gap with immediate implants. And they found there was no difference. But the only issue that I had with the study, and I really love both of them, they're both terrific, is that it was only a 10-month follow-up. And if you look at the data of the patients they looked at, the end value wasn't very high for centrals and laterals. So they didn't have a huge number of central and lateral incisor cases. It's only about a 10-month follow-up. And if you look at how thick the buccal plate was in the patients they treated, according to Cook and Mealy, they would all be considered thick phenotype patients. In fact, most of them had a buccal plate thickness of about 1 millimeter, which according to Cook and Mealy's classification, they would be considered thick phenotype patients. But they showed that there was no difference whether you grafted or not. Now, how about if you had a thin phenotype patient? And we've had a couple of those cases where they're thin phenotypes, and these are some cases, about 6 or so patients, 6 or 7 now, about 2 to 6 years follow-up that actually don't look so good. And I think that's the key. We have to look beyond, say, a year, because most of the cases that I've treated look great after 1 year, but you start to see the problem, say, around 3 to 5 years later on. And I think that's really important. And the real question is, why would we be having these problems? Even in cases where we actually grafted, these are all cases that actually received the graft. Well, you have to really go back to the basic fundamentals. This is something I learned from my classmate, Kurt Pasquinelli. And what he said is really there's basically 3 sources of blood supply to this buccal plate. And if you look at a tooth, the tooth has a rich vasculature of the periodontal ligament, you have the periosteum, but you usually don't have marrow when the buccal plate is, say, 1 millimeter or less in dimension. And the reason why natural teeth can survive with such a thin buccal plate is because the periodontal ligament is a great source of blood supply for that thin buccal plate. What Pasquinelli told me is that the danger is when you extract a tooth and you don't have enough thickness or volume around this buccal plate area is that you really only have periosteum that's nourishing that bone, that thin bone over the buccal surface of the implant, and that may not be sufficient long-term to keep that buccal plate intact. So again, what Pasquinelli told me, he's a periodontist in California, he said, it's one of my classmates from Seattle, and he basically said is that what you need to have is periosteum, which you always have, but you also need to have marrow or endosteum or vital bone around the implant because you don't have the periodontal ligament anymore. And you need these 2 factors to potentially maintain that buccal plate in dimension over time. And I think that's the key. You need to have stability over time. This has been confirmed by Spray. He looked at healed ridges, but the same would apply for extraction sockets because I think the goal of treatment is the same, whether it's an extraction socket or a healed ridge. It may be easier to do that in a healed ridge. That's why Danny Bootzer likes to do delayed, because he wants to be able to create the bone volume so that when he places the implant, he has enough bone volume around the implant. However, the discussion really is that, is the same true for extraction sockets? The answer is yes. The goals would be the same. It just may be more difficult to achieve with extraction sockets because you're limited to the size of the socket and the implant that you're going to place in the socket. And of course, in order to get enough bone volume around the implant, you may have to use a skinnier and longer implant, but that may not be sufficient to give you stability in extraction sockets. So those are some of the challenges. But the bottom line is what I learned from Boozer and Spray is that you need to have about 2 millimeters of buccal plate thickness for it to survive long term, because you need endosteum in combination with the periosteum. And the reality, it's all about biology. And I think that's the key. You have to think biologically. And that's something I learned from my partner, Dennis, and from a lot of surgeons. The only thing, though, like I said to you before, is that in extraction sockets, is that diameter may be much more effective in giving you primary stability, especially in soft bone. And the maxilla is usually characterized by soft bone. That was original work done by Alf Fleckholm and George Zarb in Brandemark's book. So wider diameter implants may be great for primary stability, but they're not really great for aesthetics. And skinny implants may be great for aesthetics, but they're very bad in regards to primary stability. And that's the challenge that most surgeons have to contend with in regards to when they place implants to extraction sockets. So this may be better, but it may not be a reality. And a lot of people tell me, well, why not just use a skinnier implant? And the answer is, you may not always be able to get a skinny implant to have good primary stability, especially in situations where you want to be able to do immediate provisional out of occlusion. And you know, after about a month after the patient feels comfortable after surgery, they're going to inadvertently load that with food. The second variable, like I said, is really about socket perforation and perforating an extraction socket. And this was in data 5 years ago, looking at over 1,200 sites. It's a CBC CT study. The average implant size was 3 millimeters by 13. Now, 13 for central would be, routine. We would mostly use 13s for central incisors. That's sort of our go-to. But a 3 millimeter implant is a very narrow implant. Now, this is a 4 millimeter cylinder in regards to, say, guided surgery. It's a virtual study. But what they decided, or what they showed, is that there is a risk, even with skinny implants, to perforate this apical part of the buccal plate because of the anatomy of the anterior socket. Everything sort of goes away from you from anterior to posterior. Now, this is with an incisal orientation. Imagine if you place the implant really in the correct position so you could do a screw retain restoration where it's coming at the cingulum. And therefore, you could clearly see that perforating this buccal plate, even with a small diameter implant, would be a risk. In fact, in the study, they said, well, how high was the rate of apical perforation in this virtual study? And the answer was 82%. So 8 out of 10 implants that they planned in this regard had the risk. Pretty significant. With central incisors having a 2.5 times greater increased risk of perforation. So these are really some of the issues we have to contend with. I'm so happy I don't place implants, I just restore them. So it's easy for me to criticize, but I understand it's not so easy to do. Obviously, the reason why the risk is that because if you look at all these studies from either Scott Gantz, Joe Kahn, Alfred Lau, and James Chow in Hong Kong, or Howie Gluckman, is that where is the bone relative to the root of the tooth? And it's usually apical and palatal to the root. So using a straight implant sometimes is not so advantageous because you're not really going to engage the maximum volume of bone in these areas, especially if you want to do a screw retain restoration. So they showed that 80% of the time, the bone is palatal and apical to the root of the tooth in these situations. Here's an example. This was a patient that was treated by a friend of mine who's a surgeon in the city, and she had placed this implant, and you can clearly see she had perforated the buccal plate unknowingly. She did take a scan afterwards, and she realized she had perforated the buccal plate, and she said to the patient, she didn't say it to me, but she said to the patient, I think that you're getting a lot of bone resorption around that implant. Well, if you look at the pre-op ridge dimension and you look at the post-op, it's still pretty consistently. And by perforating this buccal plate, could you then accelerate the loss of the buccal plate? The answer is obviously yes. Another example of a different patient that came in, also the risk of perforating this apical portion because it's just anatomy. It's just that simple. And this particular patient did have a sequestrum of the residual buccal plate, because if you perforate the buccal plate, you are strangulating the blood supply to the residual buccal plate coronal to that perforation, and hence the risk of having necrosis of that buccal plate increases. Well, we talked about the labial plate. Well, what about the papilla? Like I said, that's the second aesthetic dilemma that we have to contend with. And there are plenty of studies to say, well, if you get too close to the adjacent tooth, say 1 to 1.5 millimeters in distance, the horizontal reformation of the biologic width can actually strip the interproximal attachment apparatus. And this is pretty common. The distance between central and lateral incisor is always less than between two centrals. So the risk of having an implant placed into a central incisor is pretty high that distance is compromised, and you'll wind up losing the papilla. And this is a classic example. This is a patient who had walked into our office with loss of this papilla. Again, when implants are placed too close to the natural tooth, the reformation of the horizontal component of biologic width, whether it's a platform switched implant or not, can be anywhere from, say, 0.7 to 1.5 millimeters. And if you get too close, the reformation of the horizontal component of biologic width will strip the attachment, and the interproximal attachment is the papilla. So that's really the risk, that you lose the papilla. There's another factor, is that when you're using implants, and they tend to be either parallel at the coronal aspect or tapered, meaning they're wider at the coronal aspect, is that as the implant's being placed, even with guided surgery, and you place the implant, and maybe you don't have the stability that you really want, and you decide to actually turn that implant maybe another half turn or another quarter turn, the wider part of the tapered portion of the implant, the wider part will hit or bounce off the palatal or interproximal, and it'll tend to move a little bit to the buccal, but also to the distal, because it'll tend to move to the distal because, like I said, the distance between central and lateral is always less than between two central incisors. That's been anatomically proven in study. A little bit too far to the buccal, a little bit too far to the distal. Here's just an example of a patient who had received immediate implant therapy. You could see here again, it tends to drift a little bit to the distal and a little bit to the facial. You wind up a little bit too close to the lateral, and sometimes the adjacent root anatomy may require that the surgeon avoids hitting the root, and sometimes will also have to angulate it. So that's another variable, that the pre-existing root anatomy may dictate that the surgeon has to avoid that. This doesn't happen to be a very wide implant. It's about 4.5 millimeters in diameter, and that's not uncommon. Immediate tooth replacement therapy was done. So this is the pre-op, and at day 0, making the temporary zone grafting, 1 week and 3 months. Now, it's very interesting to note that if you look at the pre-op and you start to see the 3 months after healing, no disconnection of the temporary, that the papilla is starting to become shorter, because if you look at the height of this lateral incisor, nothing has really changed on this lateral incisor. But if you look at this height of the papilla here to here, you can notice that it's starting to create more apical. It's because the horizontal formation or reformation of the biologic width strips the interproximal attachment apparatus, and hence you wind up losing the papilla. That's again the pre-op, and you can see here after final restoration, we did replace the veneer to close off that area and also cover the exposed root that had receded, again, from the implant just drifting a little bit too close to the lateral incisor. The horizontal formation of biologic width strips the attachment, and hence you lose the papilla. Now, if you look at this X-ray after final restoration and you look at that distance is only about 0.5 millimeter. Even with platform switching, you'll lose about 0.7 millimeters of bone horizontally. So of course, if you're only 0.5 millimeter from the tooth root and 0.7, you will lose crestal bone. We actually calculated that, and we found that when we were, say, less than 1 millimeter close to the adjacent tooth, we lost about a millimeter of marginal bone. So we did lose crestal bone. So that was another factor that we had to contend with. So really, what's the solution? I think I talked about really what the problems are. Losing the buccal plate, having not enough buccal bone volume surrounding that. You need vascular bone, but also in addition to that, you also need to have enough distance and bone volume, interproximal bone volume, between the tooth and the lateral incisor. So, what is really the solution? Now, if you look at, say, all of these tapered type of implants, even say the Noble Active, which has this sort of reduced coronal diameter, but this would be, say, a BLT. This is the Astra. This is, say, a certain implant from Biomet. These are pretty standard or common implants. Is the following: is that if you try to upright that implant in order to be able to have a screw retained restoration, so more putting the implant more to the palate, but you're bringing the apex of the implant more to the buccal, you do run the risk of apical perforation. Like I said, Cochrane's study said it was about 80% or so. Consequently, you then have to angle the implant more in this direction. You may have to do a cement retain, which is not a total sin. You may do an angled screw channel abutment, provided that the amount of angled correction is, say, not more than 15 degrees. That's what Chandra Wadnati had showed. But the bigger issue is the following: is that you've actually brought the wider tapered part of the implant, which has the widest diameter, closest to where the bone is the thinnest. And that, to me, really doesn't make sense. So by bringing the wider portion of the implant closer to that buccal plate, it just doesn't make a lot of sense, because we know that we need this bone volume. So consequently, sort of inverting or reversing the shape of the implant, where you have the wider portion to engage the greatest amount of bone, like I said, palatal and apical, to the root of the tooth. That's where you have the greatest amount of bone volume. But we're at the coronal aspect, where you're really fighting for buccal plate dimension or buccal plate to reform, and also staying away from the adjacent tooth so you don't fry the papilla. I think implants really need to look like that. So we created this newer design from Southern Implants called the inverted body shift or inverted implant. Again, the idea was to not compromise the apical portion of the implant design, to allow the surgeon to actually use, say, a medium or a little bit larger size implant than, say, 4 millimeter diameter, because of soft bone, extraction socket, maybe limited apical bone beyond the extraction socket to engage for primary stability, and therefore diameter is really the surgeon's friend. But diameter is not really great in regards to then the aesthetic aspects of what we're trying to achieve. So by shrinking the top portion of the implant to, say, sort of a standard implant, say standard implant's really 375. So you could shrink it to, say, a 4 or 3.5 millimeter diameter implant, I think becomes a great strategy, because the coronal portion of the implant in the extraction socket you're not using anyhow. So making it wider and having it a potential liability to compromise the end buccal plate thickness, and also being too close to the adjacent tooth to lose the papilla or interproximal attachment, just doesn't make sense. So by reducing the coronal portion, and then maybe changing the thread pattern to make it much more aggressive at the apical portion, then you have, an ideal implant that really is designed for, say, extraction sockets where you're limited in what you can do in an extraction socket, like I said to you before, because we're just somewhat compromised in our ability to work within those confines. And the mistakes is that you're using a too large implant for whatever that socket size is. So this is sort of trying to create sort of the best of both worlds. Again, instead of being divergent at the top, it would be more convergent at the coronal portion, where you could then gain the benefits of aesthetics. So the inverted body shift concept we came up with in 2016, we're altering the diameter, the shape, and the thread pattern to enhance what we're trying to accomplish in extraction socket implants. So the bottom length or portion, more aggressive V-shaped threads, a wider or more of a tapered design. So this is the wider portion here. the length would be roughly, say, 60%, and the coronal portion being cylindrical, less threads, square threads, more shallow threads, where potentially for peri-implantitis, you wouldn't want deep threads because those are great plaque traps. And the coronal portion being roughly 40%. It's really 50-50 because there is a zone from here to here where you transition from the tapered shape to the cylindrical shape, which is roughly 10% the length of the implant. So these are just some of the strategies in the design. So again, trying to get the best of both worlds. Don't lose the identity of a tapered implant and what to do for you, but then change the coronal portion to maximize your gap distance, to enhance the amount of grafting material that you could place in this area to recreate vital bone. It's just that simple. So again, instead of having this wider coronal tapered implant design, you could actually shrink the top. Again, you would have the ability to have a greater amount of bone reformation, having a greater gap for grafting that gap, and then being able to enhance your buccal plate thickness over, say, conventional tapered implant designs. And this is just one example of what it would look like. This is from James Chow in Hong Kong. As I mentioned, James did some of the studies on the dimensions of the, where is the bone relative to the apical portion of the area. Again, the bone chamber would also apply to the interproximal. Like I said, the danger is that things tend to drift. The distance between central and lateral is always less than between two centrals. And hence, imagine if this implant was tapered, it would really be flirting with this lateral relationship. So by having this type of scenario where you reduce the coronal portion, you're not using it anyhow, allows you to really stay away from the adjacent tooth to maintain this interproximal attachment and maintain the patella. I think that's a very important concept as well. Again, labial plate thickness, tooth to implant distance, maintaining that tooth to implant distance, and having also restorative space. What I found is that by having a wider topped implant, and usually in extraction sockets, you're subcrestal on the palate and interproximal, I really had a hard time, even with platform switched implant designs. I had a very difficult time actually trying to be able to fit all my prosthetic components. And that became really, really difficult for me. I just couldn't fit all my prosthetic parts and pieces. And that became really difficult from a prosthetic standpoint. So by reducing the coronal diameter as well as platform switching, really allowed me to really have the restorative space that I really needed. And again, having more vital bone where you need it most. I think that's really the key element. Now, the implant does come in a uniaxial form. So you have the uniaxial shape where you can have a straight implant, but it also comes in a biaxial or coaxial form, which we'll discuss. And so you have a wider diameter apical portion, say 4.5 to 5, which is reduced to 3.5 to 4 on the top. So this would be a 4-5-3-5 combination. This is a 5 to a 4 millimeter combination. And again, not only straight, but also in a coaxial form. And I think the coaxial is nice because it gives us the ability, which we'll explain, to have sort of this type of screw retained solution. It also comes in different lengths. So, standard lengths from say 10 to 15 millimeters in length, which is not uncommon that you normally see for implants. Now, how does this coaxial concept work? It was really designed in 2002 for really screw retained, to have the ability to do more screw retained restorations, because the head of the implant has this sort of offset. So there's an internal offset built inside the implant. So you're changing the angulation of the implant at the implant level, not the abutment level. And consequently, if you can compare, say, this inverted coaxial design with the traditional coaxial of a tapered implant, you could appreciate that the tapered implant had a much, much broader, wider component associated with the implant. So really, by shrinking the diameter, this works extremely well for the coaxial, because the original coaxial was very wide at the top. Again, for anteriors, we're mostly using a 12-degree offset, and they all come pre-mounted with an implant mount. The implant mount actually matches the offset. So if it's plus 12 degrees, they're pre-mounted with an implant mount that matches the offset. So if it's plus 12 degrees, the implant mount is minus 12 degrees, and hence it spins at 0 degrees. So these rotate at 0 degrees so that and all you have to figure out is where is the pallet, which has the screw axis hole here. So you can get your screwdriver on the pallet, and it usually has a dot or a groove on the buckle that allows you to orient it on the buckle side. There is another benefit of this sort of inverted body shift coaxial design is that because of the coaxial, it's bringing the head of the implant more to the pallet. And therefore, it has something called a variable platform switch, which means that the buckle has a greater amount of platform switching than the pallet. And by having this sort of, shrunken diameter coronal part, again, you could fit all your parts and pieces, but you have actually more of a distance here to place more graft material. And so we're presently doing some studies looking at the benefits of just a coaxial implant with this sort of variable platform switch or this off axis, but also now variable platform switching with coaxial and inverter in combination. And we do have some preliminary data on this to say that, well, if you have more of this distance, you can add more graft material, would you be able to thicken the tissue more, especially in the midfacial area, which, like I said, facial recession is a big aesthetic problem. So we're looking at this as a means to enhance our outcomes even further just by changing implant design alone. And this is an ongoing study we now have. We've looked at what is the peri-implant soft tissue thickness if you just extract the tooth and you do nothing. You just place an implant. And the peri-implant soft tissue measured 2 millimeters from the free gingival margin is about 1.5 millimeters in thickness. Platform switching with grafting does enhance the soft tissue thickness, but variable platform switching with grafting is better than platform switching by itself. So the coaxial does enhance that even further. And we're also finding that variable platform switching with this inverted body shift or inverta shape enhances it even more. And once you're getting to about 3.5 millimeters of peri-implant soft tissue thickness, you could be very confident to appreciate that the risk of recession has been diminished significantly. I think that's a key element in this whole discussion. I always get this question, well, that's fine and dandy, but why can't I use a narrow diameter implant? And I think I mentioned that briefly before. And so to those individuals that say, well, I can just use a longer, skinnier implant. And the answer is maybe, usually not. Now, here's a perfect example. This particular patient has this lesion right over here, this internal resorption lesion. It has a fairly large root, relatively speaking, but the apical part of this area, there's a limited socket dimension in width and in length. So if anybody's going to tell me they could put a long, skinny implant in this area, they're dreaming. It's not happening. Here was the pre-op of that patient that had that distal resorptive lesion. Here's the implant in place. We'll talk a little bit more how to place them, but here's the groove that orients the coaxial in the buccal dimension. And this is a 2-week post-op with the temporary. And you can't even tell that there's any difference. In fact, the coronal tissue probably has migrated a little bit more coronal because I've under-contoured that. And that's a scenario where you'd be hard-pressed to actually get an implant in and do an immediate implant. Of course, the benefit of doing immediates is very clear. So again, here's that same case now with this implant design, the best of both worlds, having the advantage of a, say, standard size or normal or slightly larger diameter implant is a 4.5 to a 3.5 top, but having the benefit of a smaller diameter implant at the coronal section with a limited amount of apical bone to engage. And I think this went in at 70 Newton centimeters. So this is the strategies that we're now using to enhance this. And I would say to those naysayers, well, why can't I use a narrow diameter implant? And I would say to them again, well, how about this compromised socket that's blown out? you really think that you can place an implant, a long skinny implant in this area to get good primary stability? I would really question that. So with these implants, we're able to do things that we're not able to do with standard diameter implants, nor skinny, longer implants. And I think that's really a key element that people have to understand, is that by changing all these strategies within a singular design, you can now do things that you normally would not be able to do with other implants, yet not losing the integrity of what each implant could give you. So whether you're using a straight or a coaxial design, we have these aggressive threads at the apical portion where you need it. At the coronal portion, because of periimplantitis, you don't need aggressive threads, especially in the extraction socket. We also have what's called a smaller thread pitch, which means that the distance between threads is diminished. There's a great paper by Orsini that showed that, is it better to have threads that are spread out or threads that are compact? And what Orsini showed is that the more compact the threads are, really the correct number is about a half a millimeter. The more that you have threads contacting bone, the better it enhances primary stability. So these threads are only about a half a millimeter in distance versus, say, an active or a BLX, the new BLX, that has a thread distance of anywhere from 1 to 2 millimeters. And that's actually less advantageous. So you need a design like this. And some of my friends who have told me they've used other systems like the BLX, they say that to me that it's really not what they thought it would be, because it's the number of threads that are contacting bone. And by spreading out the threads, even though the thread depth is very deep and aggressive, you need to have more threads contacting per unit length of bone. And again, you only need the apical portion, which is about, on a 13 millimeter implant, would be about 6.5 millimeters. And we know that short implants can do extremely well. And I learned that from Craig Mish and Hamli Wang. Is there evidence to support this design? The answer is yes. There are presently 6 publications about this implant design, from originally a preclinical study. There's a new study that is in this month's International Journal of Oral Maxillofacial Surgery with Veronique Christians and Hugo de Brun that looked at this design in cadavers. And again, we have many different studies. This is a 2-year prospective study from PO Hospital in Sweden. And we recently published a comparative study looking at conventional tapered versus the inverted body shift implants. Here are the critical papers. This is from Nevins looking at integration with this implant design without grafting. We found that we were able to get integration without grafting, provided that we have enough gap distance. And again, this 1-year prospective study, and then the 2-year results that was just published this year. And again, this past month, we published, this clinical retrospective comparative study. Really, the inverted data is prospective, but the tapered group was retrospective. So we did it as a retrospective comparative study, as you can appreciate. And what we did in this retrospective tapered implants, whether straight or coaxial, with inverted body shift implants, whether straight or coaxial implants. And they almost had similar diameters. We looked at 21 central incisor sites in each group. So the study is only looking at central incisor extraction socket implants, a total of 42 central incisors, but 21 in each group. So we had a pretty good, grouping of case types, meaning that we didn't mix canines and laterals and premolars like many studies do. So it's only a study on central incisors. And we had implants of comparable shapes and diameters. Here you could see the difference between the two groups in this comparative study. The tapered group never really made the 2 millimeter mark, but obviously in the inverted body shift, we were able to get to the 2 millimeters and greater, which was important. Tooth to implant distance, critical, as you can appreciate, not having a wider coronal portion. If this was a conventional tapered implant, like this implant, you would have lost this papilla as well. So that would have been a problem. So again, we were able to get a greater amount of distance, again, trying to get 2 millimeters around the whole implant at the coronal part. And what's interesting, this tapered group, we actually wound up losing about a quarter of the papilla, which was interesting because when we were less than a millimeter, like I said, we also lost about a millimeter of crestal bone. So the consequence of the reformation of horizontal component of biologic width leads to marginal bone instability and marginal bone loss, which then leads to attachment loss, which means you lose the patella. And that's really the key. And in regards to the pink aesthetic score, above average pink aesthetic score is a greater than 12. As an average, the tapered group was below 12, but the inverted body shift group was above 12. In all fairness, some of the tapered group did make 12, about a third of them, but about 85% of the inverted body shift group was above 12. So we had, the bottom line is, in regards to pink aesthetic score, we had a much more consistent outcomes because the implant, from an aesthetic standpoint, was much more forgiving. And we also had a higher primary stability by about 50 Newton centimeters. We actually did a difference. We looked at all these variables, insertion torque, labial plate distance at 2 points, tooth to implant distance, marginal bone loss, and pink aesthetic score. And we calculated this difference statistically. And we found that, statistically speaking, that the inverted body shift implants did much better in pretty much all aspects. The only difference it didn't have any issues associated with tooth to implant distance between the two centrals. Like I said, between the two centrals, you always have enough distance. So that wasn't really a factor, but all the others were a factor. Again, statistically significant differences, and this is the conclusion, that we had better aesthetic outcomes with the inverted body shift implants, which led to less recession, less tooth discoloration, and less papilla loss. And that was really the key behind this study. So this study just came out. Just to finish on this topic is, what are its clinical applications? I would say in the maxilla, it's anywhere from second premolar to second premolar. That's where it was really designed. And in the lowers, it would be premolar canine. So again, you know, for molars and lower centrals, you could use different implants. But for premolars and anterior teeth, I think they work extremely well. And that's the original focus behind it. And again, it's mostly for extraction sockets. It means that you can't use it for healed ridges, but it was mostly designed for extraction sockets with that in mind. I'm just going to show one case in detail. This particular patient had a very large periapical lesion, very blown out socket. You could see that he had this type of restoration that kept on de-cementing. Now, in all fairness, he had a little bit more real estate or soft tissue here that if we had some recession, it wouldn't be as much of a problem. So these are better cases to obviously treat because you have a little bit more tissue to manage. But apically, this is the challenge in regards to being placed, you know, in regards to being able to place these implants. He also had a little of a two-side discrepancy that we can manage in regards to being able to do like an indirect composite veneer at the end, which you'll see. Originally, when we had seen him, we didn't have this new implant design, so we used a straight implant. In fact, it's 5.8 by 13 millimeters in diameter. Okay, and the bottom line is the following: we used a fairly wide implant that's 5.8 by 13 millimeters in length. So it was a fairly fat implant. Now, you can get away with this usually in males that have larger teeth. So if it's a large tooth socket, we also know males have larger teeth than women. So this is not so bad, but that's really not the whole story. Now, we made the provisional restoration out of occlusion. We saw him at 1 week, but at 4 months, he comes in and the whole temporary is mobile. And of course, your heart sinks. You can see that this tooth is loose. I tightened the temporary, but then it was just wiggling still. So we knew it was the implant that was problematic. Now, if you actually look at this implant over here, it's really not anything related to the implant. So please understand, I'm not trying to condemn any implant system. What I'm trying to say is what we can do with better implant designs, or what I think are better implant designs. Now, he sort of had this sort of black area over here, and then we took a CBCT, and we should have done that initially. And you could see here that when he comes in after 4 months, it's clear that that implant had perforated the buccal plate, or what was left of the buccal plate. Now, in all fairness, from a surgical standpoint, like I said, is that um, if patients have large periapical lesions, this can be a problem because they basically have a hole at the apex, and when you put the implant in, it walks into the hole. So, see, not using a straight implant, using a uniaxial implant. Uniaxial implants are very, very hard to place um, on the palatal aspect to get a screw retain restoration. It's easier to drill more toward the incisal edge that follows the natural bone anatomy. So it's easier to drill that way. So I think straight implants are actually harder to place without perforating the buccal plate. The risk factors, like I previously mentioned, is that an extraction socket is the pre-existing root anatomy where the patient already has an existing apical fenestration. As you place the implant in, the implant could walk into that hole, or like I said, a pre-existing periapical pathology that has a very large apical lesion can also be a pre-existing risk factor that when you place in a straight implant, by design, the implant just falls into the hole and you wind up perforating the buccal plate without even knowing it. So this is what the buccal plate looks like because it had necrosis, like I said. People say, well, what's the big deal about perforating the buccal plate? The answer is you strangle the blood supply and you wound up necrosing the buccal plate, and that was the buccal plate that had to be removed. So we start out with a type 1 or intact socket type, and we ended up with the type 2. It's in our textbook about this dysrosis, published this, as well as Dennis, myself, and Guido Sanakira, my other partner. And how to manage these type 2 sockets, it's in our textbook. And instead of using another straight implant, why not use a coaxis design with the inverted body shift or inverted coaxis design, where you could go behind this lesion and gain more of this apical palatal bone and not sacrifice having a wide implant at the top. Again, it's probably easier after talking to my partner Dennis. He feels using this coaxis design is actually easier because you're drilling more to where you have the greatest amount of bone volume. These drills are specifically made for the inverted implant. They're basically an extended solid shank drill. It has the extender built into it because obviously with an extender, the drill tip tends to wobble. So by incorporating a longer extension into the drill itself, drill shank, these drills don't chatter at all. So they're really well designed because you're only using this tip of the drill, which is roughly, say, 50% the implant length. Again, your target would be aiming toward the incisal edge. And like I said, my partner Dennis now believes that drilling toward the incisal edge is actually easier, especially for people who are just coming out of school. It would be easier for them to drill without perforating the buccal plate. You know, obviously he had to untrain himself and others because he became so used to drilling more to the palate, and then training himself took a little bit of doing, but now he finds that it's probably easier just to drill toward the incisal edge, and then the coaxis design, which is inherent in the implant body itself, will give you the screw retained restoration that you're looking for. So again, drilling more toward the incisal edge position, having a depth gauge on the implant, having the reduced coronal diameter, roughly 40%, and then orienting the buccal. The screw access hole is on the lingual and allows you then to orient the implant in the proper direction. So the screw access hole is going on the lingual, like I said. If the screw access is coming out the buccal and the mount, you're 180 degrees in the wrong direction. So this works really well. They're all pre-mounted, and hence you'll have a screw retained restoration because the implant internal prosthetic component gives you the correction that you're looking for. You don't have to do cement retain. You don't have to use these ASC abutments. And all I did was jump in the old temporary back into the temp cylinder. To manage the type 2, like I said in our textbook, an interesting technique is that Dennis will mark this cross-linked collagen membrane, which is basically like Biomed Extend, I think from Biomed, Zimmer Biomed. He likes that material a lot. Cross-link means that it's going to be stiff if it gets moist. And then what he'll do is he'll mark the membrane where it bleeds, and then he'll know where to cut the membrane. So it's sort of a cool technique. Then he'll be able to slide this membrane, basically brings the type 2 socket back into type 1, and then he grafts between the membrane and the implant as if it was a type 1 socket. That's the only difference. Very conservative, nice technique using the ice cream cone technique as well. So this is the membrane cut to its length, and then here's packing the bone as if it was a type 1 socket. The membrane is bringing the type 2 back into the type 1. Pretty straightforward, nothing magical about it. And then again, after reconstructing the lost buccal plate, but using this type of coaxial inverted coaxial design in order to accomplish that. The original implant was a 5.8, this is a 5 to a 4. So we're getting the benefit of a small diameter implant. And in fact, we're able to get a smaller implant than a 5 instead of a 5.8 into the site because we're engaging more of that palatal bone. At 1 week, there's a little soft tissue tear here. It's not a big deal. This is at 4 months. After 4 months, it was stable. Like I said, we're going to bond this indirectly. And this little tissue tear, the way that I managed is the following. At 4 months, what I did is I wound up under contouring the tempora. I just took a fine diamond burr and I went slightly subgingival just to flatten the contour. We know that contour is your friend. Learned it from Weisgold, and then you can see that at 6 months we allowed the tissue to migrate more incisal. Now we have a little bit extra tissue that we can then reshape with just a little electrosurgery. That's about the most surgery that I'll do, and I just want to sort of reshape the soft tissue shape after getting the tissue to slide more coronal. It's fairly simple. So after the electrosurgery, just unscrew the tempora. I made an implant level impression with a little flowable composite. And allowed us to pour up a soft tissue cast. Pretty straightforward. Made a metal ceramic layered crown, gold plating it, screw retained because of the coaxial feature. And then we made this a little indirect composite restoration, like I said, in the lab. Adam, our technician, this is at Tryon. I'm sorry, this is at, yes, at Tryon, where it's 7 months now after the surgery. You can see how the tissues heal. So I'm about to disconnect this and try in the crown and that little veneer. And you can see here that the tissue is starting to fill in, and remembering that we had a type 2 socket. So this is looking, pretty good. Here's the try-in. Now we're trying the crown. There's a little bit too much hypocalcification in this area, so Adam modified that. We could also try in this a little indirect composite veneer made out of grade composite just to manage the discrepancy in tooth size. He didn't want the diastema there anymore, so Adam just removed a little of this and tried this in, and then after bonding it in place, you can even see how, like I said, we're able to maintain the papilla, even though that this implant is a little bit angled, a little to the distal. That's not uncommon, like I said to you before, and how we started out and how we ended up with Roland. Interesting case because, things sometimes don't go the way you want, but we sort of try to backtrack all these issues and how we can use some of these new strategic concepts. So just wanted to show you that one case because of time and also just some differences of how we can use some of these new things. So in conclusion, if we're talking about aesthetics and implantology, what's the key? You need 2 millimeters to reestablish vascular bone. The key is you need to have vital bone all the way around the implant. It's all about biology, and biology affects aesthetic outcomes. We're talking about not just the labial, but also the interproximal. So this 2 millimeter rule works extremely well. And the inverted body shift or inverted implant, we believe in its design, it was specifically designed for this, because the coronal diameter length is roughly 40%. So we've not just reduced the coronal 1 millimeter, it's roughly anywhere from, say, 4.5 to, say, 6 millimeters, depending upon the length of the implant. We've had a significant reduction that allows the 2 millimeters of vascular bone reformation in extraction sockets, where we're usually struggling for gap distance in extraction sockets. Like I said, the dance between diameter and stability, that's always the key. With the biaxial implant design, I think we could reduce the risk of apical perforation because you can go behind pre-existing problems, and I think that case with Roland clearly exemplifies that. You can increase your risk of screw retain restorations. We are looking at that, and we're finding that Because of this, it does afford us to have a higher percentage of screw retain restorations, not 100%, but it's instead of say, say 25% cement retain, we're able to reduce it to like 3% cement retain. So that's a pretty significant difference. And I do believe, based upon the studies we're now doing, that with this coaxial and reduced coronal diameter implant, inverter implant, that we're able to enhance our peri-implant soft tissue thickness for aesthetics, meaning that we can resist having mid-facial recession over time. And I think that's really the key associated with it. Sort of want to leave you with the last thought process, and this is the following. Implant design cannot overcome biologic principles in wound healing. So there's many companies or designs that people say, well, if we change the design, we can overcome biologic principles. And that is 100% marketing. That is not science, okay? And no implant design can overcome biologic principles in wound healing. All the work from Lincoln is talking about implant depth or soft tissue thickness. It's all about reformation of the dentogingival complex. It's all biology. But what we can do with implant design is that implant design can be harnessed to work with biology to enhance our aesthetic outcomes. And I think that's the key. If you understand biology, you could work with biology to enhance aesthetic outcomes. And I think that is the key statement. So anybody who says, oh, our implant design will give you faster integration or this or that, that is marketing. That is a sales pitch, okay? It's not science. So please be aware of that. Buyer beware. So with that, here's my email address. This is my NYU email address. I'm now pretty much at NYU. And this is my Instagram account. I've learned through Instagram how to sort of navigate some things to try to get out the messaging. But with that, I'd like to thank Omar for having me on the hot seat. I've heard he's had a lot of great individuals, so I'm honored to be part of that. And hopefully I can answer a couple questions.
Thank you so much, Steve. As I said at the beginning, I truly enjoyed every second of your presentation. And I have to say that the inverted design is really something we can say game-changing, because all great characteristics of an implant that we can think about it biologically are all collected in this design, if I'm right. Because not only we have a narrower neck to provide more space for the bone, for the vascular supply, for soft tissue thickness, changing the thread designs. We have a square threads on top and 5 threads in the bottom to achieve better primary stability and reduce the stress on the crest of the bone. And regarding the primary stability, about the coaxial design for enhancing screw retain restorations in the aesthetic zone without compromising the drilling axis. So I think all the great characteristics that we need from the biological standpoint are in this design.
Yeah, we tried to think about that. In fact, I mean, what's amazing is that, most companies are really corporate driven, and they don't really ask us what we think is the right design. To sort of have engineers tell us what we should be using. But the reason why we work with Southern Implants is because it's a small company. It's a privately held. The owner, there's just the CEO is the owner, and he was willing to listen to implant concepts. I had actually met him at AO in 2016, and he was telling me about their Max implant for molar extraction sockets. And he's telling me why the Max was designed for molars and some of the challenges with molars. And on the plane ride back, I said to myself, but we have the same problems with anterior extraction sockets. We have these battles that we have to contend with. So the good news, he was willing to listen. And the implant is patented. We just received the patent actually in March of this year, last month, last 2 months. So it's nice because it's trying to provide a solution to a lot of the problems. And trust me, I have, when you've been practicing long enough, you start to see some of the issues. And no one's perfect. So we're trying to find better ways. Is Is it an absolute? Can it be used for every situation? The answer is no, and nor should it be. Every implant has a function. It should be used for a specific, purpose. So that was just some of the things to look at.
And Steve, one of my questions is regarding the drilling protocols for this kind of design. Is it similar to other designs of implants? Because I'm asking this because of different part of the implant regarding the shape. So should we, for example, do under preparation, or we should go exactly with the drilling protocol, or should we think about it biologically? I mean, should we think about the bone density and then change the scenario in drilling? Is it different or is it the same?
The answer is actually no. The good news is that there's no difference in drilling protocol. I mean, the coaxis does require that you drill more to the incisal. But hearing somebody like Adi Palti, he will show all anteriors that'll do cement retain. And the reason why he said he's doing cement retain is he has to drill to the incisal edge to avoid perforating the socket. So I totally agree with that. So if you're used to doing that, the coaxis just gives you the ability to do screw retain at the implant level. So the answer is you don't have to change any of your angulation if you're used to drilling in that direction. If you're used to also undersizing the osteotomy based upon the bone quality, and I find that, I mean, I work with, dentists been practicing not using surgical guides. And I'm not opposed to using a surgical guide. So you could use this implant with a surgical guide, provided that you're using maybe the starter drill, which I think is the most important. The starter drill gives you the orientation and the depth. And I think once you have the starter drill, then you're safe. I think once you've made the incorrect starter drill, it's hard to redirect if you've gone too wide. Yeah. But what most surgeons will tell me is that they don't like using guides because it tells you nothing about bone quality. And they say to me that surgery is a feel for them. So they feel that, if the bone quality is soft, they'll undersize. So with Inverta, you would still undersize if you're using a normal implant. So the strategy is that if the bone is soft, undersize. How much? It depends. In type 3 bone, you may want to undersize 0.5 millimeter. So you may want to drill to a 375 and put in a 4-5 implant, or drill to a 4-5 but then put in a 5. So what we're doing in soft bone type 3 and type 4 is undersizing by anywhere from 0.5 to 1 millimeter. Some people who were originally working with it said, oh, I'm disappointed because, I drilled and I didn't get the primary stability that I've been hearing about. With Inverta, you're going to get anywhere from, say, 80 to 100 Newton centimeters. But in the maxilla, we looked at those sites and we undersized about 60% of the time because in the maxilla, the bone is soft. It's usually D3 to D4. So we found that we're routinely undersizing in soft bone. So if you undersize in soft bone, you should be able to get high primary stability. In soft bone, no implant's going to be able to give you good stability. So please don't make the mistake. The other thing that came up with Saleh from VersaBurst, he said, you must use the VersaBurst with Inverta. And we said, well, maybe we should, or maybe we shouldn't. And what we didn't want to do is, if we gave them the Versa kit, then people may think that in order to get Inverta to work, you have to use osteodensification.
Yeah.
And we said, that's not true. That's the wrong messaging. But could you use osteodensification if you incorrectly drilled to the wrong diameter, meaning that you drilled it too big, and now you can't go back? Then could you use osteodensification? And in that situation, I said, well, if you made a mistake in not undersizing the osteotomy, then I would recommend using the VersaBurst to compensate for the mistake you made so that you can get better primary stability. But it's not necessary to use the VersaBurst if you understand undersizing and you're using diameter in soft bone. So that's how I would put it. Follow your normal protocol as you would normally do for soft bone. If you would undersize with a conventional implant, undersize with inverted. But you will get then very high primary stability, anywhere from 80 to 100.
Yeah, that was a great point.
That's what we found.
Yeah, and I noticed,
Like Costa, who I knew, I know that you've had Costa Nicolopoulos
yeah, yeah,
on
yeah,
hot seat, and Costa's really big on primary stability. And for him, 100 is his threshold. So originally on the design, it was Costa, Dennis, P.O. Osman, and Howie Gluckman, who actually worked with Graham Blackbeard, the owner of the company, to get the design correct. I don't place the implant, so the concept of shrinking it, okay, but to get it to work, Dennis, P.O., Costa, and Howie had to work on the design because everybody had their own requirements. Costa wanted 100 Newton centimeters, so that's why the threads were increased in its depth, made it more aggressive, maybe changing the shape. So it really works well now.
yeah, yeah. You're right. And
Sorry,
I noticed in one of your cases, it was very interesting for me that the platform of the implant was inserted about maybe 3-4 millimeters below the interproximal height of the bone. It was yeah, you know what the case that I'm talking about. You showed the radiography,
yes,
and it's I think
yes.
if we place normal implants, I mean like routine designs, with that depth, I think we will be more in trouble. And this is one of the I think benefits and advantages of this kind of design that led us to place an implant in some cases that we are forced to place it deeper comparing to the I mean interproximal level of the bone. Am I right? Because that was the point that I got.
Yeah. This always comes up, is that that's why there's a marker on the buckle that says 3 millimeters. And initially, a lot of people said, "Gee, I think you placed the implant really deep." And I said, "Well, I don't place the implants, but they do look, they're very deep." Don't forget, also when you're using, say, either a 4 or 3.5 millimeter platform, and if you go to a larger tooth, so you have more running room, so that you don't have sort of this ledge or ridge lap to your prosthetics. So and I've spoken to Linkovus about this too. The reason why the implants and extraction sockets look good is because we are placing them fairly deep. But we have to place them relative to the midfacial crest of bone.
Yeah.
That means, by definition, because of the anatomy, you're always going to be deeper interproximal and on the palate. You have to be.
Yeah, you have to.
Some of my friends had said, "Well, I'm only placing the implant relative to the interproximal crest of bone." And I said, "Well, that means then the restorative platform is supracrestal to the buccal crest of bone." I said, "How am I going to manage the contour midfacially?" And it tells me that those people who say that have never restored an implant that they surgically placed. So you have to place them deep enough, and because of the anatomy from the palate to the buccal could be anywhere, roughly 3 millimeters on average, you're going to be subcrestal, interproximal, and palatal. And as I mentioned, by shrinking the diameter, I had so much difficulty placing in prosthetic components that have sort of this flare. Most of the tie bases, they have a flare. So even with platform switching, but with a wide diameter top, even with platform switching, I would never be able to fit the prosthetic components because the flare gets stuck.
Yeah.
So by reducing the diameter and platform switching, now I can fit all my prosthetic components. I have less of a problem. So this was another aspect of what we're trying to look at in design, to be able to fit prosthetic components, because
exactly, yeah,
we could never fit them. We would have to modify them or get stuck all the time. It's crazy.
Yeah, exactly.
That was another advantage of the design.
Yeah, exactly. That was the point that I wanted to make, that we usually tend to place, especially in the extraction sockets, we tend to place the platform of the implant from the crest of the bone. I mean, like, because the interproximal peak of bone is usually
facially
3 millimeters coronally to the facial crest of the bone. So with normal
Yes.
normal
Yeah.
designs, if we placed like wide diameter platforms, we will have problem in the prosthetic phase because of the tie bases that you mentioned, and we have pressure like the bone, and resorption can happen to the papilla and recessions. But in this design, it will enhance that, and also it make it possible to place a narrow diameter abutment on top, if I'm right. So we have more
Yes.
space even interproximally.
Yeah. And yes, that's the exact thing. Now, people have said, well, aren't you weakening the implant and the prosthetics by reducing the coronal diameter? But the coronal diameter is only reduced from a 5 to a 4. So it's like using a 4 millimeter diameter implant or a 3.5. The smallest right now is 3.5. And if I talk to some of my friends like Odette Bahat, they'll say, well, I'll use a Nobel 3.3.
Mm.
Well, the 3.3 is smaller than 3.5. So the smallest diameter goes to a 3.5. And there are studies to show that what is considered a narrow diameter implant? Well, let's say this. What is considered standard diameter? Standard diameter, the traditional Brandenburg is 375. That's standard. So you could say, well, 375 to 4 would be considered a standard implant. Anything more than a 4 would be considered, I guess, a wider diameter implant. And anything under 375 would be considered narrow. Well, what's the threshold for narrow? 3 millimeters. We use some 3 millimeter diameter biohorizons in lower incisors. So, what is the threshold for a narrow? 3. So it's 3 to 375 would be considered narrow, and standard would be 375 to 4. Anything above 4 would be considered wide, and obviously ultra wide would be 6, 7, 8 wider implants. There are studies to show that once you go beyond 3, they don't do as well. But as long as you stay within 3 and 375 or 3 to 4, you're fine.
Yeah.
Now, inverted will be made larger because we realize for larger canines, larger premolars, that you may need a larger implant with a stronger connection. And we also know for, like, say, smaller lateral incisors, the 4 or 5 bottom is maybe too wide. So maybe if we went to like a 3.9 to maybe a 3.3 connection, that would actually work. And what we decided that in the coaxis, we could make it in an external hex. So we can make coaxis in a smaller and larger. With the deep conical, we can go smaller and larger, but only in a straight version, not a coaxis version.
Yeah.
Because with the deep conical, the connection's smaller, and therefore, once you go smaller with the deep conical, then people always say, what about the connection? Isn't a deep conical better? And the answer is it depends. Because with an external hex, the platform is larger. So actually with an external hex, you can actually generate more preload onto your prosthetic component because the prosthetic interface is bigger.
Yeah.
So people go, well, external hex is not as good. And the answer is it depends. Because a very small internal deep conical connection, even though it fits well, but the diameter is small, is prone to fracture. So
Yeah, right.
my answer is always it depends. It's not an absolute.
So that was actually exactly, that was my next question, that regarding the external hex and internal hex, because I saw the two options that is available in the system. So as you said, there is no recommendation on which one to use. It depends on the case, right?
Yeah, I would say that what's interesting is for single units, I like the feel of an internal connection. So for me, I just feel that, when I seat it, I don't have to worry about the flat surface, flat to flat. But understand that the deep conical is not as big of a platform as the external hex. Costa likes external hex, and in Europe, east of the United States, external hex is still well accepted. And when you think about it, the external hex has a bigger platform. So Costa likes to put high insertion torque on the abutments. So he likes using an external hex because he says it's big. So for single teeth, I like using the deep conical. For multiple units, we use the external hex because it allows you to go down to the implant level on multiple units when maybe the parallelism isn't so great. And when you even think about it, if you're using a multi-unit abutment, so say that I put in 6 deep conicals, internal connection implants, but then I'm going to use a multi-unit abutment. What we've done is 2 things. We've taken an internal connection implant and made it into an external connection implant because the multi-unit abutment basically is an external hex, right? So
Yeah.
you've taken an internal connection implant, you made it into an external hex, and you've taken a bone level implant and you made it into a tissue level implant. That's what you've done. So my saying is, so what? So what if you use deep conical or internal and external? You put a multi-unit abutment on it, doesn't matter anymore what you put on.
Exactly.
It doesn't matter. It makes no difference. So my answer is for single teeth, I just like deep conical. It gives me the feel. But really, external hex implants do just as well if you know how to use it. It's just maybe a little bit harder for people to use. But if you're using a multi-unit abutment, it doesn't matter anymore.
Doesn't matter.
And we use a lot of multi-unit abutments.
Yeah.
For full arches.
And then you mentioned that that this implant was designed specifically for extraction sockets. So is it also possible to use this implant in healed ridges or?
Yes.
Because saving more bone. Because if
let me see if I can I share my screen and just show you an example?
Sure.
Yeah. Well, what we're doing actually, what we found is that, you know, when you're drilling, let me see if I can go to a different, let me see if I can find
yeah, because Steve, the reason I asked this question was that because we have narrower part of the implant in the coronal aspect, so it's very advantageous from the biological point of view to save more bone in the crestal area instead of having the wider diameter implant. So why not?
Yes, but what we're doing is this. This became a question that actually David Garber had asked me. And here's just let me go to this and maybe you seeing my screen or you're not seeing my screen?
Not yet.
Okay, so let me see if I can share the screen.
Yeah, now I have it.
Okay. Okay. So, so this was the original intent that, okay, so you're going to drill a hole into a healed ridge, and then you're going to place an inert object in the hole that depends on the surrounding bone for healing, provided that you have enough volume still around this area, which is fine. If you have enough volume, you could use any design you want. So the original thinking was that, well, why not just then, you know, drill this amount, but leave this gap and let it fill in. Just let it fill in by osteoinduction in situ, meaning that it would just fill in on its own. But what we realized is that, well, why would we want to remove, you know, more bone? But we're removing more bone at the coronal if we're using a conventional tapered implant anyhow. So what we really realize is that in the maxilla, which is usually soft bone, in a healed ridge situation, is the following. What we realize is that because the bone is soft, that we're undersizing the osteotomy, is that we can intentionally undersize and then thread the implant in place. And then we don't have to worry about the bone filling in around the sides of the implant. So that's what we're now doing. In a healed ridge, think about undersizing the osteotomy and just threading the implant in. And here's a perfect example, okay? This is a perfect example, thin ridge up here, but you know, thicker on the bottom. Undersizing the osteotomy so we don't blow out the ridge. And then we can place the implant. Notice how the hole is smaller, and now because the bone is elastic, because don't forget maxillary bone is elastic, we can actually thread in a wider diameter implant, and we can actually expand the ridge a little bit. And you can see that there's no gap around the implant. It's completely contacting the smaller coronal section. So that's what we're now doing. That if you have soft bone in the maxilla, undersize and thread the implant in. In this situation, we just, did a little contour grafting just because of the collapse. She had a, congenitally missing lateral, so the ridge was deficient here, but you can see there's no space around the implant.
Yeah.
So undersize the osteotomy and thread the implant in. That's what we're now doing. After healing, we just sculpt the tissue, like I said, because of the coaxis that we're thickening the soft tissue here. Just a screw retain crown with veneers, and we can get, a very predictable scenario. So that's actually how we're able to do that. So in a healed ridge, the answer is yes, but use the soft bone strategy, undersize, and just thread the implant in. Then you don't have to worry about it healing and filling in.
Yeah.
And so, but it was interesting. I asked Dennis a question. I said, could we use it for sinus augmentation or like a mini sinus lift?
Yeah.
And Dennis said that in a sinus lift, there's very little crestal bone, and you want to engage the implant with that minimum amount of crestal bone. So you're doing like using the vertebra to lift the sinus, but he says you need that crestal bone to engage the cortical bone at the crest for the implant to be stable. So he said a contraindication for the inverted design is a mini lift because you need the crestal bone. You need the cortical bone. So there's a perfect example of where you shouldn't use it. But if you have a healed ridge with plenty of bone, why not? It's okay, or soft bone. But in a sinus lift, don't do it because he says the implant will then drop into the sinus.
Yeah.
So that's a contraindication, and we're actually trying to come up with a decision tree. Maybe a decision tree of when would you use it and when you wouldn't use it. You don't use every implant for every specific indication, but we do find that the implant is fairly versatile based upon what you're trying to accomplish from a biologic standpoint.
And, and speaking of different techniques, I think this is one of the designs that is very perfectly designed for socket shield cases because it provides more space to the shield and make the job easy for the dentist, doing the socket shield procedure.
Yes.
Extraction.
You doing a lot of socket shield cases?
Yeah, not a
Do you
lot.
do a lot of partial extraction therapy?
Yeah, I do partial extraction therapies since 2 years, but I mean, when I saw this design, one of the things that I thought that it makes it very easier, and the stress of the dentist, the surgeon, gonna be even lower because no worries in contacting and compressing the shield in some cases that we don't have very wide diameter socket.
Yeah, it's Howie Gluckman is from Cape Town, South Africa. So the parent company is South African. So they are working with Howie. He's actually doing a socket shield study with Inverta, and he should have the data. I'm actually doing him and Jonathan Dutoit, who's also from South Africa. And he's done a lot of studies with Howie and Maurice Solana. And what they've done is Howie wants to do like a hot seat or a conversation on May 25th. And he wants to show socket shield with Inverta and what we're doing with Inverta with, regular. There are cases, though, that really are indications for socket shield. Dennis initially was, not really in favor, but there are indications. And I think the two main indications for it, the number one indication is if you have an ankylosed tooth. So if you have an ankylosed tooth and everything is in the correct position, but to get out the ankylosed tooth, you would have to destroy the site. You'd have to destroy the socket. So Dennis feels that for socket shield, a resorbing root that's already resorbing and turning into bone is the indication for socket shield. It's not going to move. It's resorbing already, and we've found that for socket shield. Or number two is that the bone is so paper thin around that implant or around the tooth, so the buccal plate is paper thin. And and when you remove the tooth, you will have no buccal plate remaining.
Yeah.
And that would be then another indication where the socket shield would be a great indication. And by shrinking the coronal portion, it really works well for socket shield because you could still maintain that gap. We all agree that touching the root or the shield is a potential risk, not to say that it is going to be a problem, but we do know that it adds another element of risk. So not touching the shield, we would prefer that. So inverter does give an advantage with that. So you could use sort of combinations of implants where, the coronal portion is small. And in fact, I think Howie's made an implant that's 375 at the bottom and 30 at the top. And it's a straight one. It's a deep conical. And he liked the shape, but he wanted a different dimension. So Southern actually made a Gluckman version of inverter for him. And Patrick Palissy in France likes the papilla surgery. So he likes inverter because of the smaller top. So he can do his papilla surgery. So there are variations based upon its original concept, which is good because people understand what it's trying to accomplish.
Yeah.
So,
and
yeah, it's good for socket shield as well.
Yeah, and I have one more question regarding when we place like inverter design in extraction sockets. So usually because we want to save the shape of the papilla, save the height of the papilla, we prefer to do provisionals, or at least to place a long healing abutment or customize the healing abutment. But
Custom, sure.
Yeah, but sometimes
yes,
it happens that we don't have that good primary stability, and sometimes surgeons decide to place a cover screw and seal the coronal aspect with, for example, collagen sponge or something like that. So in that specific case, because we have a narrower coronal aspect of the implant, and we have placed that narrow coronal aspect deep in the bone, do we have the concern of bone formation on top of the platform and make the second stage a bit difficult, or no?
Well, let's say this. Say that, let's go back to the initial question that's saying, well, some people, if they get 20 Newton centimeters or less, we know that you can have implant survival with 20 Newton centimeters or less, but you're certainly not going to put a temporary on, even out of occlusion. So then, could they use it as a one stage with either a transmucosal abutment and maybe make a custom healing abutment out of it? The answer is yes. If you cannot get good stability, the very least I would say is do a one-stage implant, but make a custom healing abutment, and then give the patient like an Esthetics retainer over it.
Yeah.
If you feel that you don't want to make a custom healing abutment, and all the studies show that making custom healing abutments at the time of tooth extraction has a huge aesthetic benefit. Romanos and Roberto Crespi from Italy showed that they followed cases at 4 years, and they showed that if they made a custom healing abutment versus delaying a custom healing abutment, they had a millimeter less recession and 2 millimeters less ridge collapse.
Mm-hmm.
So by physically supporting the tissue, they showed that there was clearly aesthetic advantages. But if you want to use just a cover screw and then graft over it, then the risk is that the bone could grow over it.
Grow.
So I personally believe that if your insertion torque is low, then I would recommend doing a one stage with a custom healing abutment. And grafting as you normally would. I mean, making the full tooth above the gum line is just aesthetics. It's just window dressing. But what's really containing and protecting the graft is the cervical part. And we make the ice shelf for BioHorizons that makes these preformed shells that at least allow surgeons to make a custom healing abutment. So if you're running out of time, you place the implant, but you don't want to make a full tooth, which takes a long time, at least make a custom healing abutment. But we have found that with Inverta, you're not going to be getting 20 Newton centimeters. You're not, because even if you incorrectly drilled and you had soft bone and you drill to the final size, you should be able to get about 30 or 40, but you won't get 80. Most people are expecting to get 80 because that's what the study said. You'll get 80 in soft bone if you undersize. So follow your same drilling protocol as you would normally drill in any bone. This implant will enhance your outcomes, but you still have to obey the same rules of soft bone drilling protocol. If you've made a mistake, you can use the Versa burrs. Try to make a custom healing abutment at the very least, do dual zone grafting, and the coaxis is helpful for screw retained. I think that's really the bottom line. And so it's really elements that we know, but in a singular design. That was its intention.
Yeah, Steve, I have to say, I really enjoy, having this conversation with you. And, I think we can talk about it like hours and hours, but I truly first want to thank your time. And I have to say, I have one last question. And that is that I noticed that you mentioned that the length of this implant is started from 10, 11.5, 13, and 15. And I think the reason was that because it was designed for extract and socket. So if you want to place it into the healed regions, is it possible to have shorter lengths available or no?
Yes, we've asked the manufacturer. That's a very good question because sometimes even in an extraction socket, say the patient has generalized recession.
Yeah.
Generalized recession, and then the socket dimension, and then say the second bicuspid, and the inferior alveolar, the mental foramen is there. Sometimes with the second bicuspid, you can't go longer. So we've asked the manufacturer, could you make like an 8 millimeter diameter in a straight version? So the straights come in 10 up to 15. The coaxis go from 11.5 up to 15. So, that's sort of the range, depending upon the straight or the coaxis. But yes, you're right. Sometimes you need shorter implants. So they're starting to, like anything new, people who are existing Southern users and coaxis users understand Inverta, so their transition is easy.
Yeah.
But for those who have never used Southern implants, switching from one system is not so easy, but people are slowly starting to switch. And as they start to switch, then they're starting to find out there's other applications for it. So, I just think it will take time because it is a paradigm shift in how we think about things, but hopefully people appreciate it, understand it, and will use it because it has many benefits associated with it.
I'm sure.
So next time I see you, I hope to be in Tehran where we could actually drink together with a beer and continue our conversations. How's that, Omid?
Exactly.
We'll do it in Tehran, in your home, and having a beer, and then we could do another hot seat.
Good.
With face to face. How's that?
I agree. Perfect.
Okay.
Perfect.
So I look forward to it, and thank you for having me on your hot seat. And these are always great topics to talk about because you always learn more by having a conversation with friends. People always, they're more interested in, well, what did you talk about? Or what was the conversation about? Because the real life conversations of, how you manage things or talk about problems, everybody has problems. Anybody who says they never have failures or problems is not being truthful.
Yeah.
So we all have problems, but having the ability to brainstorm and think about ideas to find solutions, I think that's the key. So I think Inverta is designed to try to help people to be able to do better in the aesthetic zone.
Exactly.
So thank you for having me.
Thank you so much, Steve. Thank you so much for your time and for being such an inspiration for all of us as dentists, as learners. And keep it up. We are always your follower, and I truly recommend all the audience to follow Steve's new page on Instagram with his beautiful cases. And this hot seat going to be available soon on YouTube, and also the link will be on the Southern Implant page also, and hopefully on Steve's page. And again, just want to say
Yes.
appreciate to the max, and God bless you, and hope to see you very soon.
Thank you.
Thank you, Steve.
Thank you, Omid. You too. Be well and safe. Thank you, my friend.
You too.
Thank
Thank
you.
you. God bless.